Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today our topic of discussion in case presentation is about polypoidal choroidal vasculopathy. Polypoidal choroidal vasculopathy is basically a serous or serous-sanguineous exudative maculopathy. It is related to the repeated pigment epithelial detachments. The basic pathology is in the abnormal blood vessels in the choroid, inner choroid. These blood vessels have got abnormal endothelial cells and pericytes. Due to this abnormality in the blood vessels, these blood vessels are more prone to outpouching or aneurysm formation and ultimately to the leakage. There are a number of factors which have been associated with this, for example, hypertension, thrombocytopenia, and even certain races. For example, it is more in Far Eastern countries as compared to Caucasians. It usually presents with metamorphosias, central scotomas, and floaters. Acute phase, you can see subretinal exudation or hemorrhage, while in chronic phases, there is lipid exudation and intraretinal cysts. Later on, these patients develop subretinal fibrosis, RPE hyperplasia, atrophic retinal RPE changes. So, when will we say that this disease is an active disease? Active disease is defined when there is loss of 5 or more letters, there is pigment epithelial detachment, intraretinal fluid, or subretinal hemorrhages. And the gold standard is indocyanine green angiography. The vision in these patients sometimes may be good because of the location of these blood vessels, this lesion. For example, if it is extrafoveal or if it is minimally involving the fovea. The gold standard in the diagnosis of this abnormality is indocyanine green angiography. Indocyanine green angiography fills up these abnormal blood vessels, and when these aneurysms are filled up, along it there is a halo, and with some time this halo also gets obscured by the leaking blood. If we talk about the OCT, it is helping in the diagnosis, and here you will find a dome-shaped retinal pigment epithelial detachment with intraretinal fluids, subretinal fluids, and double ring sign, which I will discuss with you in my next slides. Modalities for this type of lesions is photodynamic therapy and intravascular endothelial growth factors like Avastin or Lucentis. And if we talk about the complications, as I mentioned earlier, they may develop choroidal ischemia, inflammation, RPE damage, breaks in the Brooks membrane, CNVM, fibrosis, and subsequent scarring. So this is a 50 years old patient, and this case is shared to us by our surgical retina fellow, Dr. Abdullah Al-Mullah, working in King Saud University. We are thankful to him for sharing this case. So let's have a look at this first slide. This patient has got central lesion occupying in the fovea, and it is a dome-shaped elevation with under subretinal fluid, and it is elevating and bulging localized lesion in the foveal area in left eye. So this is the OCT of the patient who presented to us with an emergency. The vision was 20/20, and then affected eye, the vision was 20/60, and IOP was normal, anterior segment no abnormalities. So let's have a look at the OCT. The OCT is, you can see a large dome-shaped pigment epithelial detachment. On the center of this, top of this mountain, I can say the summit, you can see some fluid, and on the sides there are also some fluid. So basically these are the intraretinal and subretinal fluids with large pigment epithelial detachment. This is basically OCT angiography. It was done, not very much beneficial. Here you can see the superficial retinal plexus, deep retinal plexus, and when we went to see the choroidal vasculature, it was not very clear. You can see because artifacts, because of their fluid overlying this, hemorrhages, and so it was not very clear and beneficial. Inferiorly, you can see the fundus photograph, and the left side lower is definitely that one, the pigment epithelial detachment and the over it fluids in the retina. And the thing I want you to concentrate, please, is that in pigment epithelial detachment, under it, the space, there is moderate hyperreflectivity. Moderate hyperreflectivity. This is a very important point which we'll discuss in the later slides. So treatment was started with this patient. This patient was explained in detail that intravitreal Eylea will be given to this patient, and there are quite high chances of developing RPE tear in these patients. And the course was started. Almost 5 to 6 injections were given at regular intervals. And later on, this patient, as I mentioned, these patients have quite high chances of developing the RPE tear. The patient developed it. And this is the OCT and face. You can see the well-localized central lesion over there, which is visible. This is autofluorescence of the same patient, and here you can see also that central zone, you can see a crescent-shaped RPE tear is present over there. And if we talk about the grading systems, it is graded from 1 to 4. Starting less than 200 micrometers and then 200 micrometers and above to the optic disc size, and above that one, and ultimately grade 4, which occupies the fovea. So this lesion most likely stays into the grade 3 or grade 4 of the RPE tear, shown on fundus autofluorescence. This is another OCT and face. Here again you can see well demarcated margins of that RPE tear and rolled margins to some extent, and centrally located lesion. So this is another slide of OCT showing over there. As I mentioned, he received multiple intravitreal Eylea injections, and now you can see that the elevation of this pigment epithelial detachment has decreased substantially. So we also did OCT angiography in the right eye, because in the lower fundus photograph in this slide you can see there are confluent drusions over there. Polypoidal Choroidal Vasculopathy is basically a bilateral disease, but when we did to see about the vasculature of the choroid in OCT angiography, it looks over there normal. There are no new vascularization, and retinal thickness, macular thickness, everything was normal. Initially I mentioned a characteristic feature of these pigment epithelial detachments, whether it is because of polypoidal choroidal vasculopathy or it is because of wet ARMD. There are two layers over there. One is the irregularly defined, this is pigment epithelial detachment, which is separated with the well-defined fluid, liquid or blood from the intact Bruch's membrane, and this is visible on OCT spectral domain. So this double layer sign is very characteristic, which I will show you now. So RPE tears basically develop in polypoidal choroidal vasculopathy, even wet ARMD they develop after intravitreal injections, and many believe that its pathogenesis is different in both. And but it has some relationship with intravitreal avastins when it is given, high or low. Many claim that there are very high chances of developing RPE, rip or tear when injections are given to the pigment epithelial detachment patients. So whenever we are going to give, we should take proper consent from the patient. Well, as far as our patient that much is concerned, his vision is still very good, 20/60, and we are still following that patient. So that was very interesting case which I wanted to discuss with you, and I hope that it will be beneficial for my respected audience also. This is a cartoon photograph which has been taken from an article. I will show you here that there are two types of forces acting on the pigment epithelial detachment. One is the fluid and the other is the choroidal neovascularization. The blood vessels are acting tangentially, shown in the white arrow, while the serous or blood that is being shown exerting hydrostatic pressure with black arrows. So this tangential white arrow blood vessels pull and the push in black by the blood or serous, they lead to such a pressure in the pigment epithelial detachment that they develop RPE, rip or tear at the margins shown in the blue arrow. So this is a schematic diagram to just show you what is the pathophysiology, how this mechanism works over there. So this is a slide which I've taken from an article. I'm showing you here. You can see in A, there are two arrows, green and yellow. Green arrow is basically showing the pigment epithelial detachment, and the yellow one is the Brooks membrane. Now, just below it, there is a moderate hyperreflectivity in A on the left side. That is polypoidal choroidal vasculopathy. But if you see on the right one, B, in between the green and yellow, which is the small pigment epithelial detachments you see, there is the reflectivity is not that much, and it is homogeneous, you can see. So this is a very important differentiating point from the CSCR from the polypoidal choroidal vasculopathy. And these are the acknowledgements. As I mentioned, this case was shared to us by our fellow F2, Dr. Abdullah Al-Mullah, and this literature review was from StatPearls, that is a polypoidal choroidal vasculopathy by Harshika Chawla, and the other references also have been mentioned. Once again, thank you for your attention.